Hello, everyone. My name is Dr. Adam Rosen. I'm an associate professor at the University of Nebraska-Omaha. I was one of the co-guest editors for this special issue in Athletic Training Sports Healthcare titled Changing the Way We Think About Rehabilitation. We have a really exciting event for you today. We have a question and answer roundtable with all the author groups from our special issue. This issue is really related to how the brain and the nervous system's role and how they control injury recurrence in a variety of patient populations. We've got some really exciting cutting edge research for you today. Alan, would you like to introduce yourself?
Yeah, and I'm Dr. Alan Needle. I'm an associate professor at Appalachian State. And I was the other co-editor of this special issue. And it was kind of interesting because this came up at an editorial board meeting, I guess it was 2 years ago now, where we saw this emerging research and it kind of led us to ask, we had the idea to come up with a special issue. So what to theme it? And I just remember at that meeting, writing down the question is, do we need to change how we think about things? And as all of this research as it relates to neurocognitive function and focus of attention and changing how we're rehabilitating, that's really the question we want to ask. And we especially want to thank all of the authors here for joining us for this roundtable and contributing to this issue to help answer that question. So as kind of our first quote unquote question, we're going to go around and in the order that the journal is listed and have each of you introduce yourself, tell us where you're from, as well as what some of the take home messages from your paper in the special issue are. So the first one up would be from Dave Sherman.
Great, and thank you all for having me. I'm Dave Sherman. I'm a PhD candidate at the University of Toledo and co-author of the Pearls of Practice column, along with clinician Sarah Sherman, my wife, and my PhD mentor, Grant Norte. This paper really hoped to introduce the utility of motor learning literature in early post-operative frame of reference. So the population that we sought to address in the Pearls of Practice column is notoriously underrepresented in the literature, but they're charged with relearning motor skills that they lost due to their impairments. So as the science continues to establish evidence for motor learning research and rehabilitation, the clinician should feel comfortable with the art of motor learning practice, especially with regards to autonomy and self-efficacy and attention, because they're closer to the patients than any researcher will ever be.
Thank you. Next is Dr. Melanie McGrath.
Hi, my name is Melanie. I am a lecturer at the University of Montana in Missoula, Montana. And I'm here on behalf of co-authors Dr. Jennifer Yentes and Dr. Adam Rosen, who are both at the University of Nebraska at Omaha. And our research article was titled Cognitive Loading Produces Similar Change in Postural Stability in Patients with Chronic Ankle Instability and Controls. And this was a research project that was part of a larger grant that Dr. Rosen was a PI on at the University of Nebraska at Omaha, where we really wanted to take a look at how divided attention, in particular during dual task, when someone is asked to perform a cognitive task as well as trying to maintain steady balance, how that might be different in patients with chronic ankle instability as well as controls. Who have had no prior history of ankle injury. And we really wanted to also utilize some different analysis tools in terms of how we actually quantify postural control. And we chose to look at sample entropy, which is used traditionally in nonlinear projects, but it really allows us to look at either the regularity of postural control patterns, or it allows us to look at how random or unregular those patterns are. And basically what we found is that when we have patients who perform a dual task single leg stance along with doing a serial subtraction, generally speaking, their postural sway becomes more regular. Basically the sample entropy value goes down. And the way that this should be interpreted is that the way that the individual is trying to accomplish maintaining this postural control forces them to alter their motor program or their motor output, so to speak. And this loss or this increase in regularity we feel actually may indicate a impairment in their balance capabilities. And so kind of the take-home message was that these dual task paradigms do seem to change the motor program and the motor pattern that we see in patients that have chronic, both chronic ankle instability and healthy controls. And ultimately, if we want our patients to achieve better balance overall, when they return to play, it's probably advantageous for them to perform a cognitive task at some point when they're also trying to maintain balance.
Thank you. The next article was co-authored by Dr. Erik Wickstrom.
Well, hi, everyone. So I'm here on behalf of my co-author, Dr. Kyeongtak Song. And our paper was laboratory and clinical-oriented measures of sensory organization strategies in those with and without chronic ankle instability. And the brief background is that we've known for a long time that balance is impaired in those with chronic ankle instability. But our intervention strategies, balance training, only seems to do part of the job in terms of improving balance and preventing recurrent injury. So we think we're missing something in either how we're evaluating those individuals or how we're setting up our treatment strategies. And of late, it seems there's some emerging evidence to suggest that these individuals struggle to re-weight or have an altered sensory organization strategy. So we wanted to go through and look at both a laboratory-based or the sensory organization test and a clinician-oriented assessment, which was the clinician or the clinical test for sensory integration and balance, and compare those two tests between those with CAI and those without. And the big take home was that both of these assessment protocols, the SOT and the CT-SIB, or you can think of it as the laboratory and the clinician-oriented assessments, identified a balance impairment in those with CAI, which we expected, but they also identified alter sensory organization strategies in these individuals. And so I think the big take home from a clinician perspective is that it's not just enough to improve balance, but we also have to think about the underlying strategy of how these individuals are maintaining their balance.
Thank you. The next article was authored by Dr. Louisa Reisbeck.
Hi, so I'm Louisa Reisbeck, and my article was written with my former PhD student, Jed Diekfers, and a colleague of mine, Dr. Christopher Ray, which some of you are probably familiar with. The title of our article was, Does an External Focus Improve Single Leg Jump Distance for Individuals with Chronic Ankle Instability? And so the purpose was just to examine the influence of attentional focus on performance using single leg jump distance as one of our measures. And so we really wanted to see if the external focus benefits could be seen when we were looking at people with chronic ankle instability on both their injured and also their non-injured limb. And we did see the benefits for their non-injured limb, which we were expecting. We did not get significant differences for the uninjured limb, although we did see performance improvements. They weren't significant. And so we think that maybe that was because they were either favoring or they were too nervous about maybe the injury that they had, and so they couldn't switch over to the external focus of attention, because when we further investigated, then we see that they were still really focused more internally on the instructions rather than the external instructions that we were providing to them. So I think our ultimate conclusion that we put in the paper was that we felt like external focus is still beneficial, not ready to maybe transfer all over into a clinical population yet with these individuals, but it could be if we use it with some education to the benefits of external focus and maybe get them away from the nervousness of the injury that they have.
Thank you. Next is Molly Taylor.
Hi, I'm Molly. I did this when I was a graduate student at the University of Oregon. So my co-author is Dr. Grace Golden. We were really diving into focus of attention as well. We wanted to kind of step back from, I think, the way that we all appreciated in really functional training and evaluate it more so in early phase rehab, simplified task movements. And so we used a side-lying position to evaluate the gluteus medius, and also wanted to evaluate the glute in a position that we hadn't really looked at it before. I think that we tend to abduct kind of past 25 degrees in most of our side-lying positions. So we were curious about getting it closer to its position in single limb stability, where it's actually in an adducted position, and see if that changed the way that it recruits muscle and allows the glute med to produce force. And so we did find that that external focus of attention still has a lot of benefits outside of functional training in a very simplified task that maybe we would use to evaluate gluteus medius strength, or even strengthen it maybe really early phase post-surgery. And we also found that being in a position closer to adduction of 10 degrees abduction actually increased how much muscle recruitment we saw in the glute med as well.
Thank you. And then the final article in this special issue was a concept paper from Dr. Ali Gokular along with some colleagues. Dr. Gokular, you are muted.
Sorry about that. Thank you for having me. My co-author,
Sorry to interrupt, but your microphone is also not transmitting that well. We're hearing little fragments.
Okay, I'm sorry about the technical issue. Goodness. Can you hear me now?
Yes.
Okay, third try. Sorry. Acknowledge my co-authors, Matthew Hoff and Pat McKeon. Thanks for having me. As you said, we published a concept paper, and it stems back to how we traditionally view rehab, where we work on impairments like reduced pain, swelling, restoring range of motion, strength, endurance, and we promote basic motor skills. But what we need to be aware of that the motor skills that we assess in a clinic is also based on a relationship between the interaction of the athlete, the environment, and the task at hand. So therefore, what you assess in the clinic is per se not the same as what an athlete would demonstrate on a field. And also stemming back to what sometimes is being referred to as an ideal movement pattern, it is our opinion that there is no such thing as an ideal movement pattern, because every situation on the field would require a relatively unique movement solution. So a certain amount of movement variability would in fact increase the adaptability of athletes to handle complex situations on the field. What we also pointed out, there may be a disconnect between rehab and the final stages like the return to sports process that might be related to a lack of challenging our athletes to cope with uncertainty in a functional task environment. So we've outlined a framework that could be used by clinicians to progress their patients from intermediate phases of rehab towards the end stages, and where we progressively add more uncertainty. And in sum, we believe that manipulating the functional task environment in order to challenge both the athletes from a physical as well as from a perceptual cognitive standpoint may be an important missing link in rehabilitation and help the athlete to cope with those demands that they would face on the field. And that, I think, from a clinician should be related to high recurrent rates of many lower extremity injuries, as well as low performance in order to get the patients back to the same level as prior to injury. So that was basically the framework that we presented.
I think Ali did a great segue into our first question here, talking about kind of the impairment-based rehabilitation at the end. And so, our first question for the group is, when we consider changing the way we think about rehabilitation, we have to consider that status quo. So, what do we see as the positives as the status quo, and then ultimately what needs to change?
I'll go ahead and start prodding some folks since we're pretty familiar with what you guys wrote. So Dave, I'm going to call you out here, as a lot of yours that really address the acute side of injury. Is there anything that we're seeing from that acute end that is very positive we need to keep doing compared to some of the changes that you talked about in your framework?
Yeah, absolutely. I mean, first of all, we do a lot of things right as clinicians in rehabilitation, whether you're athletic trainers, physical therapists, or another profession. In addressing impairments, we have to evaluate our patients and find some sort of modifiable impairment for which to build on. Our paper was just kind of changing the perspective in a way to kind of optimize what we know helps through the optimal theory, as far as building on and addressing impairments, building on a patient's motivation and expectancies for improvement. In my clinical practice, that's sometimes not always the easy thing to do. But building that rapport with the patient and making sure that any impairment, for example, inability to achieve terminal active knee extension after ACL reconstruction isn't swept under the rug in favor of just progressing rehabilitation towards a new goal. You have to make successive successes in addressing these impairments, or else that impairment in frontal plane knee range of motion is going to show up when you're going into walking or stair climbing or running down the line.
Yeah, and I'll kind of piggyback off that. I think that, you know, if we're looking at things that are going well right now, I mean, it seems like to a certain extent, doing some limited kind of dual tasking work or, you know, divided attention work is built into a lot of rehab programs already. All you have to think about is, you know, having people balance on one leg catching a ball, or balance on one leg kicking a ball, or whatever it might be. Most of our clinicians recognize the importance of challenging different systems, but I think that a lot of times that challenge ends at trying to accomplish two motor tasks at the same time. And so I think if we're looking at what needs to change, I think engaging different parts of the brain probably needs to be high up there. So looking at divided attention, as well as trying to make decision-making a component of dual tasking, and then also incorporating not just static balance, but also trying to incorporate gait, so that not only are we looking at just a basic static postural control, which we know is altered in a lot of patients, but we also see that movement patterns during gait and running are also altered in patients with knee and ankle injuries. And so looking at ways to incorporate a dual task and cognitive loading paradigm into more movement-oriented tasks is probably really important as well.
So it seems like the consensus from those two comments is that we're doing things right, and it's just some small tweaks to those things that are right. Is there anything that we're doing wrong in any of your opinions? Is there anything that we just need to find a better way that we need to stop doing?
I don't think it's necessarily that people are doing things wrong. I think it's just a matter of realigning or changing the way that some things might be done in rehab. And it might not just be from like a patient's perspective, but also from the actual clinician too. So like the way that I have been looking at things, this is unrelated to this particular study, but we also have another study where we have people been doing a balance study. It was over a 20-week period. And we went in and just had the clinicians change the way that they would typically deliver instructions, because what we were finding out was that clinicians would typically be more attracted to the internal focus instructions, because that's something that they are also comfortable with too. And so from like an instruction delivery, then I think the more that we can get out there, that if we change words slightly, then that might also benefit the way that somebody is going to ultimately affect their overall performance, and then the way that they learn a new task.
Yeah, maybe if you allow me to follow up on that, I totally agree, and also to what David said before. I think if we have our intention to have a patient relearn certain motor skills, I think it's in maybe from an historical point that we think people need a lot of verbal instructions and they need a lot of explicit instructions. So we have like 20 sentences to explain a motor skill. And then we keep instructing them. Every 8 to 14 seconds, we provide additional instructions, we provide feedback, which ultimately results that the patient is very self-focused, is not directing attention to the task at hand.
Yeah.
So I think that's one thing. So I would agree with what you're saying. The tendency would be probably to go towards more implicit ways of learning or an external focus. I think one other aspect that we could improve on, so I'm not saying that people do it wrong, but I would say that we could improve in is how we present our exercise programs to our patient. And a lot of times we have the assumption that patients learn skills in a linear fashion, from easy to difficult, from simple to more difficult. And that's just not how it works. We all have individual learning strategies, and it's our task as clinicians to find out what works best for our patient. And if you think about, it's not only in sports, but also in your daily life, when you walk in a busy street or in a train station at an airport, a lot of things happen. So you have to divide your attention. You have to revise your motor plan. So I would also suggest not to work in blocked practice. So to practice always the same motor skill over and over and over again. But I would even, let's say, to start even in early phases with a relatively high variability of exercises that constantly triggers the brain with new information, and our patient has to find a solution for every different situation. The additional benefit you get is that your patient will get out of that monotonous exercise routine, because they can be, you know, much more engaged when they have challenging exercises that changes all over the time. So I think that those are two things that I would add to anything that was said before that I agree with as well.
I'll jump on there a little bit. I think that the same way that we can consider, you know, changing the monotony of what they're doing or influencing what they're thinking about, like obviously a lot of us are proving that the simplicity of what they're thinking about can influence the rehab session. So I think at the same time, simplifying even further than that and realizing that if their brain has so much influence, then their emotions that day and their mental health and their overall emotional health and their motivation and their confidence, all of those things are such huge players that I think as clinicians, we can maybe just try and tie that in a little bit more regularly and know that day by day, even that's going to shift in the grand scheme of the brain controlling so much of what's happening physiologically. I think that we can do a better job of just tying all of those things together.
So Molly, another great segue here to our next question. You know, so then how do we get these concepts into the clinic? How do we get them adopted by sports medicine and healthcare professionals to start integrating these things into the clinic? How do we get that clinician buy-in per se?
You could offer programs where you're training them with whatever instructions or whatever task it is that you are wanting to do, and then show them the results. I think that, you know, as a coach, as a practitioner, it's hard to make a change until you actually see the results. And if you see that the results will happen fairly quickly, then you're going to be more likely to make a change. I think you could probably go to any coach and ask them, hey, do you follow the science? And they'll be like, well, does it work? Before they're willing to try it out.
And that was going to be kind of what I had brainstormed on this question is, you know, the methods need to be easy and the results need to be concrete. And so if, you know, we can demonstrate that there is a very easy, cheap, time-effective, you know, change to their current rehabilitation practice or method that they can incorporate, and that there is then a known result, right, or result that is better than what they're currently getting. And so I think being able to provide them with those two things, and whether that is something that, you know, at least, you know, here in the United States, clinical practice ultimately guides then what is taught in education programs. And so it really does become important that the clinicians begin utilizing some of this stuff that then gets fed down into maybe educational content standards so that it gets a little bit more hard baked into wider spread dissemination. And so yeah, so whether we're looking at, really trying to get into, results, patient-oriented evidence in terms of outcomes with some of these different research projects, or being able to go out into the district meetings, conferences, places where the clinicians are actually really active and disseminating this. And again, being able to provide very here's this exercise, here's this progression of exercises that you should look at, and here's what we've seen and how it actually changes better than what we're doing right now.
I could add on. I think Melanie hits a great point of the education piece. And my experience in undergraduate and graduate athletic programs has really said that we don't do a great job of teaching motor learning principles. We teach exercises and thousands of them and how to progress, but we really don't teach the underlying principles of how the brain will learn and how the body will adapt to different environmental contexts. And once you understand those principles, it's very easy to throw in and mix up exercises and protocols to achieve those goals. But it would help. I think that would really help in moving us away from essentially what I think of rehab as rehab for the test, right? We know we want good range of motion, so we do lots of range of motion exercises. But how do you integrate that range of motion into functional behavior? And everyone on this panel has already said something right along these same lines, right? It's how do you integrate it and put it into practice? And it's not just a single metric that we can just measure, right? It's teaching those underlying principles, making it fun for the athlete, and then that's, I think, where they're going to buy in and they're going to start to see that change in their own performance.
Ali, I know you spend a very large amount of your time going around the world and teaching clinicians and across a bunch of different disciplines how to implement these. Any words from your experience in running those seminars?
Yeah. So what we found out, for example, in our injury prevention programs, we know the evidence is there. But just going to clinicians and coaches and say, okay, you have to adopt this program because it's good for you, doesn't mean that they're not gonna buy it. So what we are doing, and that's also what I'm doing during my coachings, is to really ask people, what are your needs? Where can I help you with? And a lot of times, it boils down to that, what Dr. Wickstrom was also saying, that they're not quite familiar with the motor learning principles. So I need to spend some time with that. And then I need to spend some additional time after that, how they can incorporate those principles in their setting, because there is no golden egg answer. Everybody has their own, set where in time limitations, in financial reimbursement, how many visits do you get? How much time do you have per patient? And I think that needs to be all considered in order for clinicians to buy into that. So it's not really an easy answer like, okay, this is the principle and just adopt it. There are many barriers that we need to address before people can really start implementing those principles in their clinic.
So I think this is a pretty good transition too to ask really the next question is, we're hitting these components of evidence-based practice. The evidence is there. How do we get it in clinicians' hands? And of course, how do we get the patient to buy in? So do we feel like these changes are more or less likely to be bought into by our patients? And how can we get our patients more involved as stakeholders to these real rehabilitation plans? I know we've already talked a little bit where Dave and Melanie discussed a lot of the pros in getting your patient involved and addressing their motivation, while Erik also discussed some negative, it doesn't really reflect functionality, so how do we get that involved? So I guess how are we getting those patients to buy in?
if I may start, is, and I think Dave touched back on that already a little bit, where you referred to some autonomy, so some self-control. And I think and this is maybe also an area where we can improve on. I think historically, the clinicians are in charge of the entire rehab program. So we are the expert and we know what's good for our patient. And I think we truly have the best intentions. So let there be no doubt about that. But I think what we forget is what is the voice of the patient? What is what is the patient's need at any given time? And does it change over time? And I think the only way to find out is by giving the patients, or we also do that in injury prevention programs, where we give our athletes some self-control. So we, for example, we give them a certain set of exercises and they can choose on any given day which of 10 exercises, they can pick 3 exercises. So we are not telling them what to do. They pick the 3 that they are interested in doing at that time. They can even decide on, I'm going to practice that exercise for 20 seconds or for 15 reps, instead of us always telling this is your training dosage. And that gives you really a lot of information, because I can see from the sideline, hey, I noticed in the last week you always pick the easy exercises, or I noticed you only work on it for 20 seconds. Why not any longer? And now you're getting in a dialogue with your patient to find out what's going on at that particular time. And it may be that the patient tells me, yeah, I'm just fed up with these exercises. I've been doing them now for 2 weeks, 3 weeks. I'm ready for something new. Well, if I did not give my patient some input, instead of me always being in charge, I would never get that information. So I think it's really important to get into that dialogue with our patients, and then we can foster their needs, I think, much better than what we're doing now.
I absolutely agree. And I think that has to start from the very beginning, when they enter the clinic on crutches or in the knee brace or whatever, and they spend time on the table where they're really dependent on you, the clinician. It's about building independence even in those very early days in order to create autonomy and resurrect almost the athlete inside of them, avoiding any passive treatments and checking the boxes and building up their confidence.
I agree. I think it's all about connecting with them and just listening. I mean, if we're wanting to change what they're thinking about or how they're thinking during rehabilitation, I think we first have to understand how they think. And so if we're going to get that buy-in, we can't just immediately jump into trying to educate them, I don't think. I think we have to understand how best they're going to be educated. I mean, the same way that I think we're really diving into pain science education with chronic cases. It's along that same pathway of, if we can kind of get into their brain a little bit more to understand what they're thinking about and why, then we can kind of dive into that a little bit more.
Yeah, Molly, I was going to explore that a little bit. You know, 3 of our articles are surrounding chronic ankle instability. Obviously, that longitudinal condition where we have patients have multiple injuries or recurrent injury over and over again. How does that maybe change or influence some of the paradigms that we're talking about today, potentially with a chronic versus acute care case?
You mean in general with rehab, or?
In general, yeah.
I mean, I think they're huge differences. I mean, the same way, I think either way, you have to just connect and listen. But in some of our chronic cases where there's going to be more frustration and maybe disinterest in some of the more basic educational concepts that we'll throw into rehab, that's where we're diving into a little bit of helping them understand like nociception and how our bodies actually handle those chronic issues and how our bodies heal, and helping them to understand some of those levels of pain a little bit differently. And I think that ties in really well with, if we can change the cognition during those tasks, whether it is very chronic and long-term and something they've been dealing with for a long time, or whether it's more acute. I think either way, you can throw some of the same stuff at it.
Yeah, and I think that one of the things, when it comes to those longer term conditions, I think we've seen, with even some of the acute injuries like ACL reconstructions, but we're seeing it really work its way into some of the chronic conditions as well. is some of this fear avoidance beliefs and patient confidence that gets significantly altered after any major joint trauma, but particularly so when you're dealing with something that is recurrent and where individuals have probably made some changes to the way that they approach activity as a result of their own, perceived instability. So it really becomes a dual problem of there being kind of a physical component to the chronic condition that has altered some of the movement patterns or the way that they approach their motor control. But you also have this very psychological component of now that they've got this condition that they potentially have, whether it's fear or uncertainty or what it might, or as you've noted, frustration over having to deal with it for, months or years and what it may be. It becomes a little bit more of a complex issue, which again is where incorporating their feedback and incorporating their input becomes so critical. And I feel like they're the ones that are going to be able to tell us ultimately, right? Like, where are they really feeling this this difficulty or this perceived disability? And again, that's going to be potentially very individualized in terms of some patients are going to tell you that, well, I feel fine when I'm going side to side, but it's when I have to land, or it's when I have to cut, or it's when I'm doing this particular type of movement on the court or on the field. That's where they feel like they've had to make adjustments versus what we may perceive as being something important to their sport. And so I feel like that, incorporating some of that psychological paradigm is probably going to be really important. And then, as everyone has noted, just listening to what they have to tell us and then structuring around that.
I think one more thing, maybe Alan, before you were going to jump to another segue there, but one area that we I don't think we've touched on a whole lot is, if we make the assumption that the athletes want to get back onto their respective pitch or field or court, how can we try to incorporate sport-specific stuff very early on, right? They don't have to be sprinting up and down the field or doing, really high intensity exercises, but can there be a way that we can work on balance or a functional strength in a way that ties in the skill set associated with their sport? Can we pull in strength and conditioning coaches? Can we pull in their own coaches in order to find ways to get them integrated back in the team, on the training pitch, so to speak, so that they can buy in with their teammates? We can get them doing more sport-specific movements at a lower intensity. That might even be able to draw out some of those fear avoidance issues that have been talked about as well.
It's a great point, Eric. I know I'm involved in teaching a lot of strength and conditioning students here, and that's one of the big take-homes I always have, is getting that integration between athletic trainers and strength coaches to do exactly that. The next question we have is something that I've picked up from Pat McKeon. I'll give him credit for this frequent question, which is, what is the Monday message? He's a big proponent that at all these conferences, what is the take-home that a clinician could, or a practitioner can do on Monday to start implementing that changes, assuming they're seeing this on a Thursday or Friday evening? I'm going to go ahead and pick on Dr. Gokular for this one a little bit, only because you came from your paper is very, very conceptual, and it's to some extent it's part of the balance here is it's great knowledge to put out there, but it's also difficult to implement. So how do you think a clinician, what is that Monday message that a clinician can take from your paper and bring into the real world next week?
Mm-hmm. Yeah, good question, difficult answer. I think it starts with some awareness. So if you assess your patient in the clinic, don't take that as a guarantee that the patient will show the same movement on the field. Those are two different worlds. And I think as soon as you realize that the motor skills you're trying to teach your patient in your clinical setting is vastly different than the physical and the psychological and the cognitive demands an athlete would face on the field. So my take-home message for Monday would be, add variability on your balance exercise, add a dual task, and the dual task can be cognitive, but could also be a motor task. Ask them to prioritize either the motor task or prioritize the cognitive task. See what the effect is and try to identify where deficits would lie in your patient. Is it more the cognitive part? Is it more the motor part? Yes, then you would start strengthening. You would work on your range of motion. But if that all's been taken care of and you see deficits, then you need to consider, is it more a psychological problem or is it more a neurocognitive problem? And then the training intervention would be more targeted towards that. So for example, what Dr. Wickstrom was saying, like if you have an athlete and you want to work sports specific, but it's still in an early stage, maybe something like multiple object tracking could be an avenue we could explore. So it at least activates the same brain circuits in a phase that the patient is not physically able to do it yet. So I think the challenge would be to reconceptualize your way of rehabilitation. And that's challenging because it requires you to deviate from what you've been doing for a long, long time. And that's what I would say. I would not tell the people that are listening to this that you do something wrong. No, that would be definitely not my take-home message to you. My take-home message would be, we have a great panel of experts here, and take bits and pieces and apply that to your setting to improve the outcome.
Okay, I'll go next. I think that my take home, or what I would like people to think about the take home from my study, is to make sure that the instructions that you are giving are being interpreted the way that you want them to be interpreted. Because if they're not, then they can obviously have very different outcomes in the end. So mine's obviously more from an instructional cue perspective, but that would be the take home. Make sure that it's being interpreted the way that you want it to be interpreted.
Well, and I think a big part of that, because I agree, even from my study, is to consider their cognitive and mental mindset going into the day, and not just how are your physical ailments feeling, you know, how is your injury, how is this? Because if it can be so influential of, you know, the type of feedback that you're giving, then obviously what was happening in their brain before they even got there is going to be influenced in the same way that your instructions might influence them. So to always try and take that into account.
All right, well, Alan asked the pressing question. I'll ask the future question. So where do we see kind of the future of this research going? And what gaps do us as researchers need to fill in?
I'll take a stab at this. I think where we're seeing a lot of the research at the moment, right, is where we're assessing outcomes. We're developing or applying not necessarily new protocols or not even new principles. It's just something that it really hasn't been explored a whole lot in maybe musculoskeletal research or rehabilitation. But the bigger question, I think, to a lot of the comments made earlier is, how do we get that coach to buy in? Well, we have to show that when we're applying these principles, performance in their athletes is just as good, but they're also getting back onto their respective fields and they're not sustaining recurrent injuries or new injuries to another body part. So I think that's really kind of, to me, the next step is, as we develop these clinical trials, they're not just based on outcomes like better balance or better strength, but it's also based on injury rates. You know, I'll call it a motor learning program, does that have lower injury rates than what we'll call an impairment-based rehabilitation program? And I think that's where we need to start to go and fill in those gaps.
And I think to build on that is, even when we check off the boxes of the impairments and they pass the return to sport and they look good in the clinic, and when we move them, as Dr. Gokular would say, into the different world of their sport, we need to do so gradually. We can't just let them run free, and that's with communication with strength and conditioning and coaching to make sure that that transition is more gradual, so that if there are any perceptual or cognitive perceptual deficits that we've missed, maybe we can identify them through more of a 3 to 4 week, maybe even 2-month transition from the clinic to the field without restriction.
One interesting factor, I think, from this special issue is Dr. Rosen and I cast a pretty decent sized net trying to capture the articles that we were looking for. But when we look at those articles included, they seem to really only target the lower extremity and primarily the ankle and the knee. Why do you think we're not seeing as much as it relates to spine injuries or upper extremity injuries?
So I think part of that has to do with just the relative amount of lower extremity versus spine and upper extremity research that happens. We know that the knee and the ankle are certainly two of the areas where we see the most, and that's, you know, for the majority of again, the majority of sports here in the United States, lower extremity injuries are also the most common. You know, ankle injuries and knee injuries are definitely, you know, very, very common in almost every sport. And you become a little bit more specialized in certain types of sports when you start to see, in particular, like shoulder or elbow injuries. That being said, I do think that's always a gap in the literature, is things have a tendency to, at least again, in my perception, things have a tendency to lag in the upper extremity compared to the lower extremities because of the volume of research that comes out. And so I think it would certainly behoove us to encourage more researchers to look outside of the lower extremity box. And, you know, and some fantastic stuff, the fear avoidance belief stuff has really come out of the spine and now has worked its way out into the extremities. And so we see that there can be some really awesome crossover. And I see a lot of that, you know, being able to work its way into the shoulder as well. When we start talking about, you know, chronic ankle instability, shoulder instability is a major problem as well. And could a lot of these same paradigms work for those patients that have repetitive shoulder instability problems? I think it would be a really fascinating thing to approach.
All right. Well, I think we'll end our question and answer session there. We want to thank all of you for contributing to the special issue, but also joining us today for this fantastic discussion on changing the way we think about rehabilitation. So, and thank you to Slack, our publisher, for allowing us the opportunity to for this forum to bring the latest research in this realm to the readers. So thank you all for joining us, and we appreciate it.
I'd also encourage any readers to reach out to our wonderful authors here who are listed on these manuscripts, and I'm sure we all appreciate the dialogue that emerges from these papers.